a little bit of notice, and we'll kind of go back to looking at each other in the face again instead of on a computer. The other thing that I think Brand wanted to do is, since we've got these things virtually, and maybe if we can figure out a way, if we do go online to record these, is just make them more widely available to some of the other residency programs, so they can kind of look at them on their own. I think as long as we're, doing it like this, I think you guys ought to have first dibs over the fun experience of answering and getting called on. But if we had them where they could look at these and view them silently, or look at it after the fact, it just would open it up to more people. So that's just a thought too. We've got 15 cases. If we don't get through all of these, we'll just kind of roll a few of them over maybe in the next month. But anyway, why don't we go ahead and get started? And here's the first case. And hopefully your slide showed the diagnostic area. And yeah, it does have the diagnostic area on it. So anybody want to kind of describe this one?
Sure. Good morning. I'm Usman. Sorry, I'm trying to get my audio in sync. I'm Usman. Yeah. I'm one of the first years over at Baylor. So I'll describe this one. So this looks like a punch biopsy, and it looks like an inflammatory process. You can kind of see that diffuse inflammation in the dermis, composed of several types of cells: lymphocytes, neutrophils, eosinophils, and perhaps some histiocytes as well. And the main diagnostic feature, you can see in the epidermis, looks like an organism of sorts in the epidermis. And so just based on
this little structure right there, is that an organism?
That does not look like an organism.
No, that's not an organism there, but you are right. There is an organism. I just didn't want to spoil the diagnosis so quickly.
Okay.
Here's the organism, right?
Yes.
Good. So what do you think that structure was over there actually that I was showing? And then it's actually sort of pixelated here.
Mm-hmm.
Come back in a second, hopefully. Come on. Here we go. So what was I trying to point out here in this little thing?
Would that just be some scale crust?
It is scale crust, but notice the pattern of the scale crust. So, and that's actually Dr. Ackerman years ago used to have a little session a lecture he gave, like a diagnosis to the cornified layer alone, where you can just look at the cornified layer of the epidermis, and you can come up with a sort of like forensic files. You can suggest a diagnosis just looking at the type of changes in the cornified layer. For example, if it's basket weave cornified layer with organisms in it, that's tinea versicolor most of the time. If it's got neutrophils in the cornified layer, you can think of psoriasis, fungal infections, things like that. If it's kind of scale crust like here, you might think of possibly irritation or a bacterial infection. But notice that this is just very focal right here. It's in a small dell. So this is probably not really an artifact. Now it could be, but you can see that here's a little bit of an indentation over here, an indentation, kind of the normal sort of wavy appearance of the epidermis. And then you've got this little area that's kind of sunken in, and it's got this scale crust in it. And then we look over on this area over here, and yes, we do have the organism. So you know what the diagnosis is already, right?
Yes. Should I say it now, or would you like to point out something else? So my diagnosis would be scabies.
Your diagnosis would be correct. And sometimes the diagnosis is just the beginning of the educational experience. So what are we looking at here? What is this is the organism, right? There's actually probably about 3 organisms here, interestingly enough. So we're looking at a little sort of apartment complex of 3, or maybe it's a duplex. It's got multiple residents in it here. And what do you call this little dwelling where the organisms like to live in scabies.
Would this be an intraepidermal vesicle?
Yeah, but it's got a specific name to it. And you've
Name.
probably heard it.
Like the burrow?
A burrow. Yeah, a burrow. So the organism actually is tunneling through the skin. So this is a burrow. And the teaching point about this over here is this is also the burrow. This is a subtle little area that's probably either, it's probably trailing where the organism, once was. And this is kind of this is like if you ever go skiing out on a lake and this is the wake behind your boat. So this is the little burrow that's left over. So if you see this under the microscope, it's a clue to scabies. Now you can't diagnose scabies from this. This is not diagnostic of scabies right here.
Mm-hmm.
But if you see this, you say, wow, that could be a burrow of scabies. And so then you might cut deeper into the block, and then you see, what we have over here. So this is the obvious diagnosis of scabies here. So that's good that you picked it up. Now, what's the gender of the organisms here?
The gender.
That's another one that your senior residents might be able to help you with. Which is it, the male or the female mite that likes to burrow into your skin and scabies?
Is it the female?
It's the female. It's the female. And so if you look inside the organism, you'll often see eggs. And one of the reasons why that's kind of important is sometimes, when you biopsy, you may just see an egg. This is probably a piece of the mite right over here, but sometimes you'll see a little egg. You won't actually see a full-blown mite. Sometimes you'll see these little pigtails, these little curly Q structures like you see here. That's also diagnostic of scabies. So if you see that in the cornified layer, you can make the definitive diagnosis. And there's one other sort of product of the mite, so-called sibilla, which is the fecal material of the mite. And if you see that in the cornified layer in a little dell, like a burrow, like you see here, that also is diagnostic of scabies. Now, this is an interesting pattern because the classic pattern we talk about with arthropod assaults, and we talk about them as arthropod assaults. The organism is assaulting your skin and attacking it. So it's not really a bug bite in a way, so scabies is not a bite, it's an infestation. And usually the pattern is a superficial and deep wedge-shaped infiltrate, especially when it's a bite, with a denser infiltrate at the top that gets less at the bottom because obviously the antigens are up at the top and they're not present as deep in that. And it kind of depends on what the actual arthropod assault is. If it's a mosquito bite, sometimes you get a fairly dense infiltrate deep. Tick bites, you'll see again, we talk about it, and tick really is a bite. They're actually kind of latching into your skin and cementing their mouth parts into your skin and then secreting things in there. So those infiltrates can be really, really dense and look almost pseudo-lymphomatous. But they often have a ton of eosinophils like we see here. So that's pretty characteristic. If you see scabies without EOs, that's pretty unusual. Most of the time you'll see eosinophils in arthropod assault reaction. There's some that cause more neutrophils like fire ants and certain bed bugs. They can sometimes cause neutrophilic infiltrates, but as a general rule, we like to see eosinophils in arthropod assault reactions. So I would recommend knowing this. The board will show you these kind of things because they are easy and they're pathognomonic. So they're going to show you this. They're going to show you probably Tunga penetrans. They're going to probably show you a flea. They may show you a non-scabetic mite, which doesn't actually burrow into the skin, by the way. Those just kind of affect the outer surface. They don't actually cause these same kind of burrows, like a trombiculid mite that you get with chiggers, for example. They may kind of cause a superficial little indentation, but they don't actually burrow and crawl into your skin like scabies does. And the only thing about scabies too is if you get crusted scabies and somebody that's immunocompromised, they can get a million mites. So this guy is sort of pushing that a little bit. They've got maybe 3 little organisms right here, 4. Normally, it's kind of hard even to find a mite in a biopsy of scabies. So it's kind of unusual. So when you see this, it's pathognomonic and you've got a diagnosis. So there, I'm pretty sure everybody got that one right. Wasn't a problem. Okay, good. All right, let's move on to the next case. Anybody want to give this one a go?
I can do this one. Dr. Cockerell, can you hear me?
I sure can. You sound loud and clear.
Okay. Awesome. This is Suzanne. So here we have a punch, and from this power, there's a little bit of perivascular inflammation. I'd be leaning more towards inflammatory at this time.
Good.
And then we can see there's some compact hyperkeratosis. There is some para as well. And the epidermis is a bit acanthotic.
Good. Now, when you say acanthosis, that just kind of means, increased thickening, if you will. Anything else that you might describe about that acanthosis? Is it psoriasiform acanthosis? Is it, regular, irregular? How would you kind of describe these epidermal redi here?
I would call it irregular. It doesn't look psoriasiform.
Yeah, it's not really floridly psoriasiform like we would see in psoriasis. I totally agree with you. And it is irregular. You've got these sort of thick, fat epidermal redi that have sort of probably coalesced in a couple of areas, like over here. And so that's actually a clue to this diagnosis. And when we see this entity, which I'm sure you probably already have a good idea of what it is, you don't really see the florid, prominent, long, thin epidermal rechia like you see with psoriasis. So that's helpful. Tell me a little bit about that cornified layer. So we just talked about the scabies mite with that little burrow. What about the cornified layer here?
So this one has more of kind of like an alternating pattern of parakeratosis.
Yeah, it does.
And,
I agree with you.
Now, and it kind of alternates in both. Sorry, go ahead.
You go ahead. Go ahead. I think you're about ready to say what I was going to ask you about. So.
Yeah, so it's alternating in both the vertical and horizontal.
Good. So if you were to just kind of, if we draw our little arrow here, it goes from here to here, and here it's parakeratosis, thick, compact orthokeratosis. And then if you kind of go sideways, it goes here's parakeratosis and orthokeratosis and parakeratosis once again. So that's really, if you see that, should scream a diagnosis to you, which I'm sure you probably know what it is. So what did you think this was?
Pityriasis rubra-pilaris.
Yeah, this is PRP. So this is really classic, and the changes down here are helpful also. That you don't really get. Now, sometimes they have these sort of atypical PRPs that can look a little like psoriasis, both histologically and clinically. So sometimes you can get some overlap between the two, but usually in a diagnostic case like this, you don't really see the florid elongated epidermal redi. So if the board's going to show you a case of this, they're probably going to show you this, and they might show you one other feature that we don't have here. Now, if we had this half of it, you can still make the diagnosis up here. This has even less acanthosis than the first one had, but still got the same cornified layer change. And that really thick hyperkeratosis, that sort of almost laminated hyperkeratosis, really characteristic of PRP. And the scale of PRP, it's different than psoriasis. It's not, doesn't have that micaceous scale. You don't get the flaking. It's a little different type of scale, and obviously the erythema is different. There's one other thing they would probably show you on the board that we don't have on these slides here, which would be what? You can play the game of read online. They might show some acantholysis. So that's a little bit more of a, you kind of have to, that's a more subtle, less well-known finding in PRP. But there's one thing that we do commonly see in PRP.
Follicular plugging and shoulder
follicular plugging, that's the key. And clinically, you'll see the spines, and you rub your hand across their skin, and it feels like you're rubbing across a nutmeg grater or Nestle's Crunch Bar, that sort of thing. So that's characteristic. And if you look inside the actual cornified layer of the follicle that's got the spine coming out of it, it's got that same kind of ortho and parakeratosis. So if we cut deeper, maybe this is at the edge of a follicle, you'd see that same kind of parakeratosis in there. The inflammatory infiltrate in PRP can be variable. You can have almost no inflammation like here. Sometimes you can get a little bit of spongiosis. Sometimes you can get some eosinophils. So you can see several different types of inflammation. You mentioned the acantholysis. That's may or may not be a tiny bit of that here. It's may just be artifactual, but that's actually something you can see. You don't usually see acantholytic disc keratosis with PRP, but if you see something that looks psoriasiform and it's got some acantholysis and it's got this kind of cornified layer change, you should think of PRP. There are like 6 types. There's the childhood type, there's HIV related type, and all this atypical types. I don't think you need to know all much about that for the board examination, but just know that sometimes PRP can be difficult to diagnose and there can be some unusual patterns. But if you have something like this, you can make the diagnosis. Okay, good. All right, we've got the next one here. This is a beautiful example of this entity.
I can take this one, Dr. Cockerell. This is Carly.
Yeah.
So we have a punch biopsy, and it looks inflammatory from this power would be my guess.
Okay.
We have a little bit of a kind of compact stratum corneum to start with. The epidermis otherwise itself looks okay, maybe a little bit of sponge on one of the edges, but otherwise epidermis looks okay.
Okay.
And then we get almost this Gren zone or area of dermis before we see what appears to be a lymphocytic infiltrate in a band.
Good. Lymphocytes, they're black at low power. And I like what you said, sort of like a little band. Okay. So this is not lichenoid, right? Why is this not really lichenoid? Now, a lot of people get sloppy and they call it lichenoid, but this isn't lichenoid.
Lichenoid tends to, it's like at the DEJ, and so it should also have an interface.
Absolutely correct. It's one of the interface dermatitis, and it really should obscure the dermal-epidermal junction. Those lymphocytes really ought to be just hugging that epidermis. So it's not really lichenoid. A lot, you'll hear people describe it in conferences, lichenoid. Well, if you feel brave, hold your hand up and say, Dr. Cockerell said it's not lichenoid because it's not really obscuring the dermal-epidermal junction, and it's really not. So, and that's kind of important because this diagnosis really does not usually give a true lichenoid infiltrate. So this band-like infiltrate of lymphocytes is a helpful description, just like you said. And we also talk about another type of pattern that you may not have heard of. We talk about patchy. Like you think about if you patch your jeans, if you get a hole in them. I was a kid when we got a hole in our jeans, we patched them. Today it's fashionable to have a hole in your jeans, but so you put a patch here and then it's normal over here, and then you get a little another area, you get a little patch here. And so it's sort of, you can see that it's not just kind of a diffuse band-like infiltrate. It's kind of what we call a patchy band-like infiltrate. So that's also a helpful finding when you're looking at this diagnosis. So let's go to higher magnification. And did you see anything else here that helped you with the diagnosis?
On higher power, there were some of the superficial blood vessels looked like they might be a little dilated.
Okay. What about the epidermis? Is this if we're just looking at this field here, is that normal? I mean, if I took a biopsy of your skin and looked at it, would we see these changes right here that I'm pointing out to you?
No.
No. What's abnormal about this?
Some of them look like they might be little lymphocytes.
Yes.
Going up into the epidermis.
Yes, absolutely. There's a lymphocyte, there's a lymphocyte, there's a lymphocyte. So there are like aggregations of lymphocytes, and there's some present singly at the basal cell layer in some areas. Some people call that like an eyeliner sign. I mean, I've never thought of that, but I guess that's maybe that looks like an eyeliner to some people. But to me, you can see that there's epidermotropism of these lymphocytes. They're present in the epidermis, and notice that there's quite a few, and there's really not much spongiosis here. Now, if you have a spongiotic dermatitis like contact dermatitis or nummular dermatitis, you can get lymphocytes in the epidermis there, but you usually have relatively prominent spongiosis there. So there's a ratio, a balance between the amount of spongiosis and the amount of lymphocytes. Get quite a few lymphocytes with very few or minimal spongiosis. That's really should be a red flag to a certain diagnosis.
Like MF.
Yeah, like mycosis fungoides. Here you've got a little bit of spongiosis, but it's not like a small microvesicle. You got a lot of lymphocytes in the epidermis over here. And again, you get these single lymphocytes at the basal cell layer. That's a very helpful clue. Now, notice I'm not really talking much about the morphology of the lymphocytes. So I don't really care whether they're really very atypical or not. In fact, if you ask me, it's kind of hard to appreciate atypicality of lymphocytes in the epidermis in early mycosis fungoides like this. It's really hard to tell. It's really more the pattern. So if you see this pattern here, this superficial perivascular band-like infiltrate, like you described, this kind of patchy that we talked about, with epidermotropism of lymphocytes at single lymphocytes at the basal cell layer, or even going above the basal cell layer, with minimal spongiosis, that's mycosis fungoides until proven otherwise, basically. So it's presumptively MF when you see that. So this is a beautiful example of patch stage mycosis fungoides. We wouldn't even hedge this diagnosis. So there's an institution that's about maybe 600 yards from your main campus over there. And we send a lot of biopsies, they're not second opinions, but they're seeing patients in Dr. Dubik's clinic over there for MF, and we call it MF. And then they underdiagnose everything. They don't call anything like this patch stage MF. They call it band-like infiltrate with epidermotropism. But to me, this is classic mycosis fungoides. And when you see patients like this, they have the classic patterns. They have patches, they have these irregular arciform lesions, they're itchy, they don't go away. So to me, it sort of does a disservice not to call it MF, because if you start treating the patients at this stage, you can cure them. And you can cure them with relatively minor therapy. You can cure them with sometimes narrowband ultraviolet B phototherapy, sometimes even topical steroids will kind of put this in remission. Nitrogen mustard, obviously, but you want to get it and diagnose it at this stage if you can. So the textbooks say it takes a lot of biopsies to diagnose MF, but if you get this pattern, it takes one biopsy to make the diagnosis. So this is classic. Hopefully you guys all saw that. Now, there's one or two other clues that can help you with this that I'll kind of show you. If you see thickening of the collagen bundles, and normally if you look at a normal person's papillary dermis, they really don't have thick, ropey collagen bundles in the papillary dermis. This doesn't have defining quite as well as some cases of MF, but that's a manifestation of the disease being chronic. And we all know that mycosis fungoides, it doesn't come up acutely. I mean, they may get it and then, it starts out super early and then it doesn't respond to treatment, it hangs around. And usually by the time they come in to see you or get a biopsy taken, it's got this kind of thick collagen because it's a chronic disease. It's been there for quite a while. So did you guys all think this was MF? Was it certainly in your differential, hopefully?
Yes.
Good. So this is beautiful. It doesn't get much better than this. So if you were to get something like this on the board examination, it's going to be something like this. This may be a little bit too sophisticated for a board question, because they might think that people might argue that it could be a spongitic dermatitis, but this is what MF early stage patch stage disease looks like. And when you get later stages, you get denser infiltrates, then you start getting the protease collections, all those sort of things. The only other thing I would say, the opposite of this pattern is if you see patients that have Sézary syndrome, they actually get minimal epidermotropism, kind of lose the epidermotropism, becomes more leukemic in that stage, and you still can get the patchy band-like infiltrate, but you don't get as much epidermotropism in that, and that's really, unfortunately, the hardest diagnosis really to make is probably the epidermal changes in Sézary, because they just don't have a lot of epidermotropism. Okay, next one.
I can take the next one. This is Tara. So this is a punch biopsy. I'm not really seeing much inflammation in the derm. It doesn't really look like any kind of neoplasm either. There's just a lot of blue in the dermis.
Okay, good. So the general category we think of is inflammatory neoplastic, but there's a couple of sort of asterisk exceptions to the rule.
Like deposition, maybe.
I'm sorry, I didn't hear you.
Deposition.
Yeah, like a deposition of something. So yeah, you kind of have to think a little bit outside the box. say, generally inflammatory neoplastic. Well, maybe it's not either one of those. And then you start saying, well, maybe it's an abnormal deposit of something, but we'll talk about that. So what part of the body are you on, or can you really tell?
It's kind of hard to tell, but I mean,
there's a couple of little clues. So we know a lot of places where it's not, right? It's not on the face, certainly not an area where there's a lot of hair. There may be a couple of hair follicles in there, but they're not very many, at least in this person's biopsy.
Yeah.
It does have these kind of vessels here that are thick-walled and kind of prominent. So where do you see those kind of blood vessels?
On the legs.
Yeah, on the leg. So that's kind of a helpful clue to this. So what's the deposit?
Mucin.
Yeah. Why is it mucin?
I mean, it's like this light blue color in between.
Yeah. It's kind of bluish gray like this. And we see bluish gray, that's favors mucin. Now there's lipid can sometimes look like that, but pretty much you see this kind of bluish gray material. You can say this is almost certainly going to be mucin. And where does this mucin come from? There's actually two types of mucin in our body.
Ground substance, like how
it is ground substance, which is what's the name of the ground substance?
Hyaluronic acid.
Yeah, hyaluronic acid. And what produces the ground substance?
Fibroblast.
Yeah, fibroblast. And probably some people think mast cells may contribute to that. But yes, they're like produced by these little fibroblasts that are sitting in here. And when you look at somebody that's got a pool of mucin in there, you're almost always going to see a couple of mast cells in there too. They just almost always go along with it. There's one other type of mucin though. What's the type of mucin that when you get a cold causes your nose to get stuffy?
I mean, just like, is that produced by the lungs? I don't know.
It's produced by goblet cells. So it's epithelial mucin. So you can have both mucin produced by epithelium, which is a more acidic mucopolysaccharide. And then you have the mucin that's the higher, the mucin like this, it's produced by the mast cells and fibroblasts, which is hyaluronic acid, which is supposedly less acidic. I mean, that's an old board question they used to ask, but it looks a little different. And in the skin, in addition to mucin that's maybe produced, like say in a mixed tumor of the skin, for example, something like that, that's more epithelial mucin, you can actually get mucin in the hair follicle and follicular mucinosis. So that's a different kind of mucin than this mucin. So just as a general kind of teaching point. So if this is on the leg and you've got this massive quantity of mucin here, what's the most likely diagnosis?
Pretibial myxedema.
Yeah, pretibial myxedema. Now, just so we, is there any neoplasm that this could be? Are there any neoplasms that produce a lot of mucin with them? And I mentioned mixed tumor of the skin, which can, basically a chondroid syringoma. And the reason it turns into cartilage is because the mucin undergoes cartilaginous metaplasia. But are there any other tumors that can give you lots of mucin? It's probably something you should at least know about in the back of your mind, because it's something that sometimes as a dermatologist, you kind of have to function a little bit as a gatekeeper for when a weird disease kind of comes your way. You're going to refer it out, but you don't want to miss it and let it sit there in your practice for too long. And then somebody, says, hey, you should have sent this to an oncologist sooner because, and now we're going to come after you because you missed the diagnosis for too long. So you should at least know that there are some tumors that have a lot of mucin, and some of them can actually be aggressive, can be malignant.
I'm not sure what you're getting at. I mean, I can think of like a mucinous carcinoma, but this doesn't really look like that.
No, it wouldn't look like this at all. But something like a myxoid lipoma or a myxoid liposarcoma or a myxoid, there's a myxoid type of malignant fibrous histiocytoma. So sometimes, and myxoid change in dermatofibrosarcoma protuberans, you see a myxoid, a lot of mucin in a neurofibroma. And I've seen myxoid changes even in desmoplastic malignant melanoma that can look like this. So when you see a lot of mucin, a situation like this, with clinical information and everything, this is pre-tibial myxedema. But if I just showed you this field at high magnification, you should throw some of those other things in the differential diagnosis. So, because you can get lots of mucin in other tumors too. So if this came in as a large, giant, plaque on somebody's back and they did a punch out of it, you should say, wait a minute, we're not just going to think it's pre-tibial myxedema or benign focal mucinosis, which it may be that, but you want to at least think about those other entities. So you're right, this is none of those. It is pre-tibial myxedema, but just remember that sometimes you can get lots of mucin in some pretty dangerous, innocuous looking lesions. And if you're dealing with a soft tissue tumor like DFSP, those things are almost like, it's like Google Maps. I mean, it can look like one thing in one area and a totally different thing in another area. And if you biopsy Main Street, it's going to look totally different than if you biopsy, Broadway. So, you have to realize that in these large tumors, they get multiphasic morphology, talk about biphasic, triphasic. So taking a punch, you can miss it. So just remember that as more of a teaching point. But that's a good example of mucin. Now, one other final question. Do you need a special stain to identify that as mucin?
I mean, there are special stains.
Yeah, people love to do special stains. It's a good way to make money, but do you really need it?
I
mean,
mean,
did you need it there, or could you tell based on what we just saw?
maybe if it's classic, you don't need it, but
You don't need it. You don't need it. In fact, the problem is they're so sensitive, it'll pick up the normal background ground substance that all of us have in our skin. And then people start saying, well, there's an increased amount of mucin. Well, it might be lupus. It might be, GA and all that stuff. And it can actually lead you down a cul-de-sac. So I never order stains for mucin. You can see it on H&E. So anytime you can see something on H&E, you don't really need a special stain, the vast majority of the time. So that's just another pearl. So if somebody says, well, did you do a mucin stain on that? You should say, you don't need a mucin stain. That's a crutch. So you don't need it.
all right, thank you.
Okay. Who wants to give this one a go?
Hi, Dr. Cockerell. This is Edgar. I'm one of the first years here at Baylor.
Great.
So here we're looking
at. You guys all come with a title. I can tell who it is.
Here we're looking at a punch biopsy. It looks inflammatory to me. See some inflammation in the dermis, also down into the subcutaneous fat as well.
Yeah, good. And what's the pattern of the inflammation here?
So if we're looking at superficially in the dermis, it seems to be more perivascular, maybe periecrin. Whereas down in the adipose tissue, it seems to be a little bit more lobular, maybe mixed. Doesn't seem to be septal though.
Yeah, it kind of looks like it's sort of involving everything, doesn't it? It's kind of going all the way from the top to the bottom and a little bit perivascular, but it's also pretty interstitial too.
Yeah.
So if you want to grade, say, here's maybe a little perivascular up here. And then here it's mostly interstitial. If you want to say, okay, well, is it more interstitial or is it more perivascular?
I would say probably more interstitial here.
Yeah, absolutely. I would totally agree with you. So it's interstitial mostly. It's perivascular, but it's kind of mostly interstitial. And it is, you're right, it's going all the way from the top down to the bottom. And these fat lobules are involved. The septa of the fat are thickened. There's also this change up here.
Yeah.
Any idea what we're pointing out in this area?
Maybe some acanthosis. It seems like
there's a little bit of thickening in the epidermis. So what's this white area here I'm kind of pointing out to you?
Is it?
Look at these little strands here. These are the little
just from
papillary dermal
edema,
strands.
maybe.
They're like, go ahead.
maybe like edema,
Yeah. This is edema. This is papillary dermal edema. And these little strands here, they're almost like, strings of a kite, and they're trying to hold the epidermis. They don't fly away, stay here, don't form a blister, because it's getting ready almost to form a blister because it's so edematous. So you can imagine what this would look like clinically. What do you think this would have looked like if you saw the patient in your practice?
Yeah, so I would think like if it we're like dealing with like lower extremities, it's probably some deep pitting edema.
Yeah, it's gonna look edematous, and yeah, it might be pitting edema. You're exactly right. It's probably gonna look red because a lot of inflammation. It's got edema. It's got this really diffuse interstitial mostly infiltrate. And what kind of cells were in the infiltrate?
So from this power, I guess we can see probably some lymphocytes.
There are some lymphocytes, but there's also some of these cells in here.
We'll also see some, looks like eosinophils.
I think most of those are extravasated red
blood cells. Yeah, red blood cells.
But these cells that have two lobes to them,
probably some neutrophils.
So you've got a diffuse infiltrate, interstitial mostly. Look at these neutrophils over here. Polys with papillary dermal edema. And we don't get very many biopsies of this. And the reason I included this is because it's such a classic, beautiful example of it. We hardly ever get biopsies of this because clinically, you don't need a biopsy. Usually you see these patients come into the ER, they got fever and they've got that clinical description, and you just make the diagnosis at the bedside and you stick them on an antibiotic. But this guy took a biopsy for some reason. Maybe he might have thought it was a bullous disease, because it had this edema, and he might say, gosh, maybe this guy's getting bullous pemphigoid or something. So they took a biopsy of it. But so what's the diagnosis that we're describing here?
I was thinking maybe we can have like so this is like a stasis derm that's evolved maybe into like a lipodermatosclerosis.
But does that usually give you this interstitial mostly infiltrate with all these neutrophils in it?
I guess not necessarily. You wouldn't see as much of the neutrophilic.
Yeah. And there might be some background stasis type change that led to this process. So, you get people who got bad circulation and they get, maybe they're shaving their legs and they nick it. And the next thing you know, they've got this disease.
So is it like, not just not just cellulitis?
Or... Yeah. This is cellulitis. This is a biopsy of cellulitis that you almost never see a biopsy of cellulitis. But if you do biopsy it, this is what it looks like. And so basically what's happening here is you've got this diffuse pyogenic bacterial infection. You don't usually see like an abscess in cellulitis because it's, staph causes abscesses. Cellulitis is usually, in the old days, it was caused by strep. And, back in the 1800s, before they had any antibiotics, if you got staph, it would form an abscess and you lance the abscess and, drains and the patient gets well and they live happily ever after. If you got strep cellulitis, they used to be called blood poisoning, and they'd often get, bacteremia with that because they had no antibiotics, and they would often die. So that was a bad situation in the old days. But today, obviously, we have antibiotics. We can cure this. But this is what a biopsy of that looks like. And you can see, like in this, sometimes you can get staph cellulitis also. But notice that this gives you more of a diffuse interstitial mostly, and that's called phlegminous inflammation. Now, it's got neutrophils in the infiltrate predominating, but why is this not Sweet's disease? How come it's not Sweet's?
I'm assuming because it's not as confluent. Maybe it's more diffuse, not as organized.
Yeah, that's partly correct, but also in Sweet's you get a very dense, diffuse infiltrate, usually up in this kind of area, of just a sea of neutrophils. Get tons of polys kind of filling this area, and you get papillary dermal edema with Sweet's also, so it can look, edematous, and it actually sometimes can lead to bullous lesions. But in there, you don't get the more diffuse pattern that involves, all the way down to the fat. In fact, it may be all the way going down into the fascia. In some patients with strep cellulitis, whatever. They can, necrotizing fasciitis also, all the way down to the fascia. So it can be a pretty bad disease in some cases. And of course, you can get MRSA now, and staph can cause cellulitis too. But this is what a biopsy of cellulitis looks like. So it's in the interstitial, mostly inflammatory patterns. We won't go through all that differential today, but that's something that we will go over in more unknowns down the road. But that's something you need to know. So that's good that you were able to, we ferreted out that diagnosis here. Okay, who wants to give this one a go?
I'll take this one. This is Jennifer. So we have a pretty broad shave, what looks like a solitary lesion. Starting at the top, we see a little bit of compact keratosis at the top. The epidermis from this power looks like maybe it's a little atrophic. I guess it kind of depends on location. But the main thing is we see this very dense basophilic infiltrate throughout the entire dermis.
Okay, do you think it's more of an inflammatory or neoplastic process?
Inflammatory.
Good. And so you described the pattern right there. You said it was a very dense, diffuse infiltrate. And you said that a lot of these cells are dark, so they're probably going to be lymphocytes, especially over here. What about these other cells? Are these going to be lymphocytes when we go to higher magnification?
No. So they're definitely not blue enough. So we're thinking there's some kind of mixed infiltrate going on.
Good. So they're probably going to be maybe some histiocytes in there. Another cell that can kind of look a little bit sort of slightly pale, at low power are plasma cells sometimes. So there may be some plasma cells when we go to higher magnification also, but it's a really dense, diffuse pattern. Okay. So do you have any ideas at low power about differential diagnosis?
I mean, obviously I looked at it earlier, so I have some ideas, but I mean, at this power, I guess kind of moving in now, you can see that there's a little bit more, there's these spaces, these very tiny spaces that you can kind of pick up.
Like these spaces here, or you mean these spaces kind of up here?
Kind of just throughout.
This is a pretty good clue, though. I mean, at low power, not that you need to use that for diagnosing at low power, but if you see something that's really a dense diffuse infiltrate like that, it's got lymphocytes, but it's also got some other cells. Well, they're histiocytes, but this doesn't look like a suppurative granulomatous pattern, and it doesn't have a lot of pseudoepitheliomatous hyperplasia like we would see, say, in something like blastomycosis or a deep mycosis or something like that. But it's got these pale areas at the top. That's seen in this disease pretty commonly. You get low power, you say, this reminds me of this pattern that we see in this entity that you're gonna figure it out and tell us what it is in a minute. But let's go to a little higher magnification. And indeed, we do see some histiocytes here. Okay, there's some. We don't see a lot of polys, though, do we?
No.
So it's not really the classic suppurative granulomatous infiltrate. And now you've got these areas here that this is what you were talking about, right?
Yes, those. And then we did see some giant cells as we were moving into higher power as well. And then, within these spaces, whenever you see these, you always want to think if there's some kind of organism. So kind of two things on my differential come to mind with these spaces, which would be like a leash or a histo.
Okay, good. Which of those do you favor?
I'm favoring the leash, just given kind of the distribution within these spaces.
What kind of distribution are you seeing?
Like the marquee sign on some of these, where you have more of the peripheral placement as opposed to histo, where you have more of the haphazardly arranged organisms.
Good. Now, can you get these diffuse sort of involvement inside the histiocytes in leishmaniasis also?
Yeah, I would think so.
You can. And which form usually gives you that?
Oh.
You don't have to tell me the actual
know.
name of the organism, but usually the old world will tend to give you more of kind of diffuse involvement of the histiocytes as opposed to the marquee sign. The marquee sign is more commonly seen in the New World form of leishmania. So the leishmania Donovani that you see over in Middle East and that sort of thing, that tends to give you more of a diffuse involvement. If you get the Braziliensis form and those kind of things, that tends to give you more of the marquee sign. It's just a pearl. It's not always that is true. Now, you mentioned histoplasmosis. Does histo usually give you this type of inflammatory pattern?
I don't think so.
Good. No, it usually does not. So you can look at the actual organisms inside the cells and try to decide whether it's histo and leishmania. That's one thing. But if you see this really dense diffuse pattern like this with these, pale cells at the top like this, that's almost pathognomonic of leishmaniasis. Histo almost never does that. So yeah, we can look and then say, well, yeah, let's look at the actual organisms. Histo doesn't give you the marquee sign, which is true. And the other thing, if you can't, this doesn't zoom high enough, but if you really look very carefully, you can see that there's really no capsule around these organisms. You can actually appreciate the little capsular material around histo if you look at it carefully on H&E. And you can also tell there's a little tiny dot inside these organisms. You barely make that out here. That's the little kinetoplast that the cilia attaches to when these organisms, are motile. So here they're not motile, but that little kinetoplast is there. So when it goes through its life cycle and it makes a cilia, that's actually what it sort of attaches to. There's a little, probably myofibroblast or something that causes it to vibrate. And so that you can actually see that with the H&E, and you don't really see that obviously with histoplasmosis. So you can tell the morphology of the organism looks a little bit different, and the pattern of involvement in the histocytes is different. But the third pattern is the dense diffuse infiltrate, which is really very common in leishmania as opposed to histo. Histo usually gives you more of a diffuse infiltrate that's relatively sparse. The organisms almost look like, sometimes you'll actually see neutrophils with nuclear dust. It can simulate vasculitis more than this pattern. So this would strongly favor leishmania. And you don't have to live in Mexico to get leishmaniasis or live in Central America. We actually have it in Houston. We have it in Dallas. We have it all over Texas now. So it's not endemic only south of the border. So we do see it here. Okay, good. Any other? Everybody get this one right, or at least that sounds like a resounding yes. Okay, this one's a little different.
Hi, Dr. Cockerell. I'm a first year.
Okay, great.
So from this power, my eye is most drawn to this kind of dense aggregation in the deep subcutis.
Okay. What part of the body are you?
Acral.
Good, excellent. And you can tell that obviously by the epidermis. It's thickened and acanthotic with this prominent hyperkeratosis up here. And there are no follicles here. So those are all clues that you're dealing with volar skin. Now, if we saw a couple of hair follicles in here, would that be volar skin?
I would think maybe scalp, or like, I know that there's some hair on the back of the hands.
Yeah, it really wouldn't be volar skin because we don't have any hair follicles there unless you're maybe a gorilla or something like that. But if we saw hair follicles and we saw this markedly thickened cornified layer, what would we say had to have happened to the skin?
Like lichenification?
Yeah, good. It has to have been rubbed. So that's just a clue. Here, there's no follicles, so you say it's almost like more likely acral skin. It's not lichen simplex chronicus. So getting back to the actual diagnosis, yeah, the changes down here in the lower part, maybe almost beneath the skin. And did you think this was an inflammatory or a neoplastic process?
So because it's so discrete, and I didn't see that many changes up above, I favored a neoplastic process.
Good. Yeah, it's not comprised of any inflammatory cells, or if they are, there may be forming a neoplasm. We see inflammatory cells like in the mycosis fungoides case we had earlier. That's a neoplasm, but it's comprised of lymphocytes. So here, if there are inflammatory cells, they're kind of forming this nodular aggregation here, multinodular aggregation that may be forming a neoplasm. Now, do you think this is a benign or malignant neoplasm?
So given that it's fairly well circumscribed, but when we zoom in, I see kind of minimal pleomorphism. It appears pretty symmetric. I don't see any necrosis. I would favor benign.
Good. Those are the very good reasons. Now, we obviously have a punch biopsy. So, I mean, this could have come out of something that was 5 centimeters large, and we just have one area that doesn't look pleomorphic. So you kind of have to use, you can't use all the criteria because we don't have the entire lesion. But based on what we have here, this seems like a small little nodule aggregation. And if we say, well, this is, representative of the whole thing, it's got a nice smooth border to it. And then, so if you look at this one aggregation, it looks pretty symmetrical. So the little piece of the puzzle obeys the rules for benignity. And then, like you said, we go to higher magnification, and you don't really see any mitoses, pleomorphism, atypicality, anything like that. Do you think this is epithelial or non-epithelial?
No, sir, non-epithelial.
Yeah, non-epithelial. Why non-epithelial?
Well, the cells seem to have like a spindle morphology.
Yeah, that's the number one reason. You can get epithelial neoplasms that have spindle morphology. We see spindle cell squamous cell carcinomas, things like that. But as a general rule, we see things like this. We tend to favor this being non-epithelial. Certainly, there are no cells that are forming desmosomes. There are no cuboidal cells that are hugging one another. Those are the kind of things to look for in an epithelial lesion. So of the non-epithelial, there's really three main cell types that we deal with in dermatopathology. There's more, but the three major ones. Which of the three main ones do you favor this being?
I like fibroblasts.
Yeah, fibroblasts. And why fibroblasts as opposed to another type of spindle cell lesion?
Well, they kind of have the almost corkscrew-like looking morphology to them.
I agree. I think they kind of look jagged. They're kind of irregular. They don't have that sort of lazy S-shaped morphology we see like with a neural differentiation. They don't have the cigar shape that with a periapical vacuole that we see with muscle. You look between the individual cells and there's this sort of pink material like here that's probably collagen. So yeah, that favors fibroblast. And then if we look over here, we see lots of thick ropey collagen bundles that are being formed from these fibroblasts. So yeah, that's exactly what they are. So based on all of that, what's your diagnosis here?
Well, given that we are on acral skin and it seems to be a pretty well circumscribed fibroblastic proliferation, like either palmar or plantar fibromatosis.
Good. So when they call it palmar fibromatosis, what's the other name for that entity?
I know I'm going to mispronounce this, but Dupuytren's contracture.
Yeah, Dupuytren's contracture. That's good. Exactly. So good. That's right. This is in the family of the so-called fibromatoses. There's about 7 or 8 of those that you sort of have to know about, and we don't spend a lot of time on these in dermatology. They really are sort of more orthopedic, but you can get desmoid fibromatosis that can be associated with Gardner's syndrome. So that's something you'll, of course, with colonic polyps and colon cancer, and that's a board type question. So just remember that one. You can get giant cell tumor of tendon sheath, fibroma of tendon sheath. That's in the family of the fibromatoses. Torticollis, Peyronie's disease. Those are all in the same family of entities, and they all basically, if you do a biopsy of them, they all look just like this. They all have similar morphology. Now, if you get giant cell tumor of tendon sheath, you'll see these large osteoclast-like cells and osteoblast-like cells that are comprised of that. But they all kind of generally look like this. So that's good that you were able to get that diagnosis. It might show you something like this on the board. Not going to promise they will, but at least if they do, it's fairly straightforward. Okay, here's another good example of this entity.
Hey, I can take this one. Can you hear me?
Yes, absolutely.
Okay, perfect. So this looks like maybe a shave of like a pedunculated type lesion.
Yeah, it might have been sessile or sticking above the skin, and they just kind of shaved off the whole thing. Absolutely.
And there's this proliferation of like anastomosing basaloid strands. So I favor more of a neoplasm here.
Good. Neoplasm. Epithelial or non-epithelial?
I would say epithelial.
Yeah. Which type of epithelial?
Basal cell epithelium.
Well, it's basaloid. Yeah, basaloid.
Yeah.
You're right. Now, obviously, if something is kind of basophilic, basaloid, that can come from a couple of different structures. So we think about differentiation of epithelial neoplasms in the skin. We have to think about what normally lives there. So what normally lives in the skin that's got some basaloid cells in it somewhere? There's a few things, but there's one major one that does.
Are you talking about like follicular?
Yeah, the hair follicle. That's the number one area. And there's two places of the hair follicle where basaloid cells live. So what are the two main places within that normal hair follicle structure where you can get these sort of primitive basaloid cells like we're going to see with our higher magnification here?
Maybe like the hair, like bulb area.
Yeah, the hair bulb. Good, excellent. The inferior portion, the hair bulb, that's the second most rapidly developing entity in your proliferating in your body. Bone marrow's first, and hair follicles are second. And that's why if you get chemotherapy for something, your hair falls out because those cells are proliferating rapidly and they get killed by those anti-metabolites. And you get those same type of cells up here. What's this area called? That lives right beneath the infundibulum of the follicle, just before you move into the inferior portion.
The isthmus.
It's the isthmus, but we also call it the mantle zone, mantle area.
Okay.
That's where the stem cells live, and some of those cells, branch off and form a sebaceous duct and sebaceous lobules. Others can form apocrine glands, and then others form the inferior portion of the follicle. So, when your follicle undergoes the cycling, anagen, catagen, telogen, those little mantle zone stem cells are what give rise to the new follicle that forms. So sometimes they can form a tumor, like you see here. This entity, some people think actually is a quote mantleoma, if you will.
Okay.
So it shows these basaloid cells, and they are differentiating towards the follicle. This is primitive follicular epithelium. So what's the diagnosis here?
Well, I initially thought it was a fibroepithelioma pincus.
I think your thought is correct. That's exactly what it is. That's what it is. Now, we call it fibroepithelial because you got this prominent fibrostroma here, and this is the epithelial part of it. But yeah, that's exactly what it is. And what do people think that is in general?
A variant of a basal cell.
Yeah. And it probably really and truly isn't. But sometimes you'll see areas that really look like a classic basal cell, but it's really more of an adnexal tumor that's probably coming from these primitive mantle cells, and it forms these little strands, these anastomosing strands and cords, like you said. And some areas are more solid over here with this prominent fibrostroma. Whenever you get a prominent fibrostroma, where the stroma almost is present more than the epithelium, that tends to favor a low-grade biologic lesion. In other words, that's more commonly seen in like a trichoepithelioma, in this lesion. So these people come in and they may have had this for 25 years. And maybe they say, well, my bra strap's starting to bother it, or maybe my belt buckle's bothering it now, or whatever. And you take a biopsy and this is what it looks like. And, it hasn't ulcerated, it hasn't gotten larger. So it's really very low grade lesion. Probably, if they call it your attention, it might never be a biopsy. So a lot of these usually come in as rule-out skin tag or nevus. Nobody really thinks of them as a basal cell, and then they get the diagnosis back, and usually go back and re-excise it just to make sure it doesn't come back. But it's obviously a low-grade lesion. This is exactly what this is: fibroepithelial tumor of Pincus. Okay, great. So anyway, you can think of it as a basal cell, but it's probably not truly a basal cell. But when you get that basaloid morphology, think of follicles, you can think of sebaceous glands, you think of things that kind of live in that mantle zone area, the germinative cells of a sebaceous lesion can do that. Do you guys have time for one more, or what's your time frame here?
Yeah, we can do one more.
Okay, good. All right, this is kind of a cool case also.
Okay. Hi, Dr. Cockerell. My name's Christina. I'm the other first year.
Okay, great.
So looks like we have several sections of a punch biopsy. With looks like just from this high power view, we may be on an acral surface,
Yeah,
given the appearance of the stratum corneum.
looks
And
pretty
looks like
similar to the skin in that fibromatosis, doesn't it?
Yeah. Looks like our activity is kind of centered in the dermis, deeper dermis area here. I would call this inflammatory.
Yeah.
It looks like we do see some inflammatory infiltrate.
What kind of cells are these at low power? You're going to favor that they're going to be?
They're not really black, so I would say not lymphocytes.
Good, good. And they're kind of pale, aren't they? So they look relatively large even at low powers, but at higher magnification, you can see that there's some lymphocytes, but a lot of them are histiocytes. And notice the arrangement of the cells. How are they kind of arranged here?
Yeah, so they're kind of circumferentially located around this more like lighter pale pink material.
Yes, good. They're kind of forming a little ring, if you will. They're saying, hey, wait a minute, something's going on here, and we're going to kind of wall this stuff off, kind of keep it from posing a problem. So good. So you got a granulomatous inflammatory infiltrate, and you notice this material in here. And so how do you describe this material?
So looking at it closely, you can kind of see kind of these wispy lines in the material.
Good.
And so it made me think that maybe before there had been something linearly shaped in those areas like needles, needle shaped things.
Yes, they are needle shaped. So when you see something like that, it tells you that it probably was a crystal. So we see several crystals we can see in the skin. You can get crystals from cholesterol, and we actually see those in the skin. You get clefts, cholesterol clefts. But it's these little fine needles here with this kind of wispy, almost looks like cloud-like material between the individual crystals. That's very characteristic of what this material is. Do you have any idea of what that is?
I think it's gout. That's what it looks like.
It is gout. It's pathognomonic of gout. So this is one of the ones that you want to look at, recognize, and say, this is gout. And basically, what's the inflammation doing here?
It's kind of like a foreign body reaction almost to crystals.
That's exactly right. This is a foreign body. Normally we don't put gout crystals in our skin. And when they come in there, your body says, wait a minute, this is somebody who's almost, they may have well injected this in your So yeah, it's actually a foreign body reaction. So that's exactly right. Now, what they might try to do on something like this. So if you're a kind of somewhat of a nefarious writer of board questions, they're going to put some things on the differential here and try to trip you up. So they're going to say the A, granulomedullary, B, intralesional Zyderm injection, or exogenous collagen injection. All those things give you palisaded type granulomatous inflammation surrounding something like that. Rheumatoid nodule, they might put that in there. So you'll have to face that question probably, because that's what they're going to want to, they're going to show something like this. They're going to show some granulose inflammation like this. And they're going to expect you to recognize the gout crystals. So you don't need a special stain for this. It's basically just like you said, you see these needle-like clefts in here that indicates that there was gout material in here at once upon a time. If you polarize this right now, you wouldn't see anything because the gout crystal's been washed out in the processing the tissue. If you were to take this tissue and put it into 100% alcohol and then make a slide out of it, you could polarize it at that point. It gives you that refractile refringent by doubly refractile refringent material that you can actually see the crystals, and it kind of looks brown in the skin. So that's what gout would look like if you saw it was preserved in 100% alcohol. So that's good. So that's if you're a first year resident, you got gout already, that's great. You don't have to worry about it anymore. You can think about other more difficult things.
Good, thank you.
Okay, so we got through 9. So next month, why don't we go through the next 5 of those or 6 of those? What do we got left? And then we'll send you some more. And once we actually get to do this virtually, we'll go through all 15. And I think we usually have a little bit longer than an hour when we actually fly down there. So we usually start a little bit earlier. So hope you guys enjoyed the session. And if you have any questions, feel free to email them to us, and we'll make sure we get another set of slides off to you guys for the next session. And let me know whenever we're going to go back to live, and we'll do that.
Thank you so much.
Thank you so much.
Thank you,
Okay.
Dr.
Take
Cockerell.
care. Have a good way.